Следующее слово представляется профессор Барекет. Она представит свою работу. Поднимите, пожалуйста, вторую. Спасибо большое. Еще раз просто напомню, профессор Барекет является заведующим роговичным отделом при самой большой израильской больнице в Тель-Шамер, которая находится в Тель-Авиве. Она также рефрактивный хирург и катарактальный, и с радостью поделится своими мыслями об этой работе. Я еще раз только спрошу у публики, как мы хотим лучше спрашивать вопросы в конце лекции или в конце всей сессии, как вы предпочитаете? Если есть вопросы какие-то профессору Цадоку по предыдущей работе, то тогда продолжим. Спасибо.
Thank you very much for attending this session, and thank you very much again for the kind invitation to attend this wonderful scientific meeting, and even welcoming us yesterday. It was snowing here, and from 27 degrees in Tel Aviv to a bit of snow, it can't get much better than that. So thank you very much. And I want to discuss another topic related to the outcome of our cataract patients, and that is related to irregular astigmatism. So it all started with a text message that I got from a friend a few months ago. He said that he's a brilliant cataract surgeon, and he said that he operated on a simple case, but the patient was very unsatisfied with his vision and complained of bursts, and his visual acuity was 618, and the OCT of the macula was normal. Here's an upside down smiley, but I don't think it shows here. So then he called to ask, maybe I have an idea. So I said, well, you had a biometer that incorporates instantaneous preoperative topography, don't you? Let's take a look. And then he pulled out the preoperative data showing some irregular astigmatism that involves the visual axis, and that might definitely explain why this beautiful operation resulted in a suboptimal vision. So as Professor Tzadok mentioned, in the modern era of refractive cataract operation, patient expectation is really high of improving their vision, independence of glasses, and the astigmatism is often addressed at the same time with the phacoemulsification procedure, because otherwise it can preclude significantly the vision. So we know that regular and symmetric astigmatism can be addressed typically with a toric lens or corneal relaxing incision, either with a laser or manual, or even by utilizing the effect of the cataract incision. What happens when there are vision disturbances and astigmatism but no other pathology? Well, if it's regular, then spectacle correction will provide adequate vision. But if there's a significant amount of irregular astigmatism, glasses won't correct well, and then we can always use a rigid gas permeable contact lens to improve the vision and undress the astigmatism. But things get more complicated when there's vision disturbances, astigmatism, and cataract, because then the assessment process is much more challenging, and corneal topography will provide the important information on the degree of regular and irregular astigmatism, and the other tests may be difficult to interpret or help distinguish if the limited vision is related to the cataract or the irregular astigmatism. There are some treatable causes of astigmatism that they affect the cornea and limit the postoperative refractive benefit of cataract surgery, and they need to be addressed and treated prior to cataract surgery to improve both biometric assessment, refractive prediction, and of course enhance the final visual outcome, such as pterygium, epithelial basement membrane dystrophy, or dry eye syndrome. If there is irregular astigmatism, then we need to look if it's in the periphery with a relatively symmetric and stable central cornea, such as in peripheral scars or prior LTK or very mild form first keratometric that is still symmetric in the visual axis. But then if there's a central corneal irregularity, then the key for the appropriate surgical approach to evaluate the amount and the impact of the astigmatism is by central topography to ensure also the stability over time. So I'd like to share with you a few cases that I had in the practice, starting from an easy one. It's a 65-year-old female with decreased vision in the left eye, her refraction was plus 1.5, minus 2 diopters of astigmatism that show partially also in the keratometry. And on examination, I saw just mild gutata and a nuclear cataract. And here's the biometry showing a mild amount of astigmatism, not really pointing at any significant problem. But looking at the topography, we can definitely see that the involvement of the visual axis might be much more prominent with the irregularity, especially under mesopic condition, and the incision should be addressed and related to the topography. And here's another one. This is a 70-year-old male that used to work in agriculture, came in with decreased vision in the right eye, no significant eye history. His refraction was plus 275 with a very minimal amount of astigmatism, showing both in refraction and in the keratometry, and the exam was unremarkable except for cortical and nuclear cataracts. And here again is the biometry with a mild amount of astigmatism. But looking at the topography, I realized there's a significant amount of flattening and irregular astigmatism involving significantly the visual axis. So I asked him if he had any other problems that he did not mention in the initial history. And then he said, no, really not really. Oh, but a few years ago, he had some pterygium removal, about 15 years ago, which he forgot to mention. And this would not be picked, evidently, by the biometry. And here's a third one. 65-year-old female with cataracts, pseudophakia. She had RK, which you are probably much more familiar than we are, many years ago, and then she had PRK for enhancement and remained with a residual subepithelial scar. We can look at the refraction and we can see that there is a certain amount of astigmatism. The magnitude was stable, but the direction was slightly different by different exams. But again, looking at topography, we can see the flattening that is significantly displaced inferiorly, both in the topography and in the tomography. We can see the thinning, but also the displacement and the irregularity in the visual axis. So we went ahead and performed a biometry by 3 biometers, the Lenstar, the IOL Master, and the Tomei, and we can see that there are different amounts and directions of astigmatism in each of the devices, and posing a big question how to proceed. So I went ahead and calculated the selection of the intraocular lens using the ASCRS website, and here I ended up having a wide variety between 18.33 to 21.5 diopters of selection of the lens. So I decided to just go for the safe middle way and implanted a 20 diopter AMO ZCBOO, and the surgery went uneventfully, and 6 weeks post-operatively I was pretty lucky because her visual acuity showed mild amount of astigmatism. She ended up with a 6/12 vision probably because of the irregularity, but she felt significant improvement in her vision and she was really happy. And here's the fourth case, and this is a 55-year-old woman. She is in the managerial department of my institution. Very nice person with very advanced keratoconus, deep amblyopia on her right eye. So this was the only eye. And after a lot of effort, she was successfully fitted with a semi-scleral contact lens, minus 25 diopters, mini-scleral lens. Developed rapid decrease with her vision in the left eye. She went to the optometrist. He reached only a 6/18 vision. He was unable to improve her visual acuity, and he sent her back to consider keratoplasty because he thought that the fitting of the lens ended up here. So on examination, I realized, and it was interesting to see that there was a lot of distortion due to the very prominent cataract, but there was a very dense posterior subcapsular cataract. She developed progressive vision deterioration requiring operation. And here is her topography. And we can see the huge amount of steepness of her cornea with up to 77 diopters by 70. And here's the tomography that supports exactly the same findings. And here there's a lot of challenge in advanced keratoconus to calculate the intraocular lens to be implanted because there's thinning and ectasia of the cornea causing keratometric myopia and irregular astigmatism. There's a significantly greater anterior chamber depth and significant errors of the estimation of the corneal power. The assessment of the power is really inaccurate because the keratometry is inaccurate due to the corneal distortion. There's a change in the normal relationship between the anterior and the posterior corneal surface. There's displacement of the apex of the cone, and the visual axis may not pass through the steepest portion of the cornea. And if this is not enough, there's always irregularity of the tear film reflex, causing difficulty for repeatable keratometry values. And here is the IOL calculation, and resulted of a suggestion for a minus 43 diopter implant, which is of course not feasible. So what's the best approach? Wait for a significant visual deterioration and then operate. Remember, it's a 55-year-old woman, very active, it's the only eye. Perform first keratoplasty and then cataract operation for full visual and refractive rehabilitation. Go ahead and perform a triple PK or DULC with cataract extraction and IOL, or still opt for the cataract operation alone. The patient was very comfortable with her contact lenses, but with a very severe deterioration in the life quality, refused keratoplasty, and was really eager to return to normal life as soon as possible. So my solution was using the standard K values of somewhere between 43.5 and 44 that I usually use for IOL calculation in triple PK cataract IOL, enable her to resume scleral lens wear. And here are the calculations based on this 44 diopters, resulting in a 15 diopter lens suggestion, and this is what I implanted. The operation was uneventful, and the postoperative course was uneventful. And at 3 weeks after the operation, she was refitted with a new semi-scleral contact lens, a minus 11.75, and she reached a 6.6 vision and a J2, and with reading glasses, she even reached J1 and was back to work. The standard K values that are usually used for the estimation of IOL power in triple procedures are a viable option in advanced keratoconus because the patient will anyway require a rigid or a scleral lens for visual rehabilitation, and the implantation of an IOL in available powers, and she's actually ready if the patient will need keratoplasty in the future. So in conclusion, cataract surgery in eyes with irregular corneal astigmatism is very often challenging and mainly requires awareness, and a personalized plan is essential. Also, it's very important to educate the patient expectation, and by incorporating the analysis of corneal astigmatism at the time of the cataract evaluation, a surgical plan that addresses both conditions may provide our patients with the best vision possible. Thank you.
Вопросы к профессору Брекет, если у кого-то есть. Thank you very much for your very interesting and challenging cases in this presentation. Я продолжу дальше.